So while you have a think, I get the chair's prerogative to ask one. Given that we've heard from Darryl about the resources that in-hospital cardiac arrests use, we've heard from Gemma about possibly an age cut-off for neurological outcome. From Julie, we've heard about a personal experience of DNR. My question really is not a very easy one, but are we at the stage now where we should stop providing resuscitation by CPR by default, and that it should be an opt-in rather than an opt-out system?
No.
Discuss.
Well, I think if you're going to start this opt-in, opt-out system, people need to make an informed consenting decision about what they're buying into or not. And this might be a bit of a controversial view, but I think in the main, most clinicians have a strong sense of what is in the best interests of a patient or not. And while I'm all for shared decision making and setting collaborative goals of care, at the end of the day, it's me that makes a decision about whether I do this or not. And I think in the main, clinicians do make good decisions. So I think unless you're going to start this really big campaign and people are fully informed, and I'm not sure even if people are fully informed if they're making an informed consenting decision. So I think no.
What do you think, Gemma? You've shown that over 70s have quite poor outcomes. Should we be providing this treatment to them by default without asking their consent?
I think the most important thing is the goals of care discussions. I think that is, we're getting better at it, but I think we've still got room for improvement. But I remember reading a study about when patients were asked what they thought their likelihood of survival would be after CPR, and they think that it's actually a very high percentage. So I think, the ability to make an informed decision is limited, so it needs to be clinician-led, but very much a goals of care discussion as well.
And do you think we're having those conversations often enough and well enough, Darryl? Outside of the Austin, I mean other centres.
No, I don't think we particularly do it fantastically as well. I think advanced care planning should be done by general practitioners and clinicians in the community, and I think that we have an opportunity to do it for surgical patients who come in to pre-admission clinic. And I think if you've had an admission to the hospital and you've survived under a medical team and you're at risk, I think once you go back to outpatients, I think I agree we should have goals of care discussions, but having advanced care planning and detailed informed consent once patients are unwell, I think it's impossible. I don't think they're in a position to provide informed consent. And I agree with Julie, it's more assent, where you're actually providing genuine information about the likelihood of success, and it's more assent than consent. That's my perspective.
Okay. Any questions from the floor? Hello.
Hi, this is Billy from Darryl. We actually did a study that looked at consumer attitudes for looking about how they would choose their surgeons around infection, and they didn't want to know. It's too much information. So how would you think that if you did all this preparation, how would they be receiving it? And would they be too anxious about what they were going to have with their surgery to even be able to understand it and comprehend the implications for it? So what are your thoughts on how you do it?
So I think it's highly patient variable, just like it is with everything. I think we've got a group of patients that want the clinicians to make all the decisions, and at the other end of the spectrum, we've got clinician-assisted dying in Victoria now. So, there are clearly some people who want to take total ownership of the way they die, and there are some people who continue to trust, rightly or wrongly, the clinicians that are caring for them. And I think it's shared patient decision-making. We can't be paternalistic in every case, and we can't be involving the patient to the nth degree. And we need everything in life is tailored to a situation, balanced.
Any other questions? Yeah.
I was just wondering, why do patients have a good neurological outcome or a better neurological outcome the shorter their time in hospital?
There's actually a couple of studies that have looked specifically at this variable, and they have suggested that the longer duration of hospital admission is related to the level of comorbidities that the patients may have, specifically renal disease, cancer, and sepsis. And they also think that potentially because of those things, they're less likely to have a shockable rhythm. So yeah, I think it's multifactorial. But I was quite surprised that was the independent predictor at the longer term outcomes. Another study looked at frailty in these patients as well, and the deconditioning that may happen within the time that they're in hospital. So yeah, I think it's quite a complex picture, but those are a couple of things that came up in previous literature.
So, Gerald, let's take outside of the Alfred and the bigger teaching hospitals, training around CPR for in-hospital arrests that are now rare events, and who's on that team becomes important for success. In our hospitals, that is often the most junior of the learners who are leading those response teams. So how do we improve that success if the people leading that resuscitation during the daytime or at nighttime are the most junior learners in what's becoming a rare event?
So I think our focus is to train the responders to a large degree, and then for everyone else, it's quality chest compressions, push the bed out and get the defib and get the pads attached. And that's as simple as that. So you need to train the people who are most likely to be the responders well, and everyone else gets basic training. And I realise, I acknowledge, that some patients will have delayed defibrillation with a shockable rhythm, but that's not the most of our arrests, and more importantly, the investment to get that 1 or 2 patients per year is humongous. And we have trouble getting people released. So even if you have the staff to do the training and the time and the cost to do that, to get the learners released is very difficult, particularly with the doctors. And I want to be clear, I'm not saying that doctors shouldn't learn how to do ALS. That's not what I'm saying, because they can benefit from the community, and the community might very well expect doctors to know how to do ALS. What I'm saying is it is not a good investment for a hospital to train every doctor how to do ALS. It's a much better investment for teaching them how to prevent the cardiac arrest in the first instance, because that has other benefits, not just in preventing cardiac arrest, but preventing infections, prolonged length of stay, unplanned admissions to the ICU, improves teamwork and morale on the ward, gets people to have an ownership of their own patient, etc., etc. You know, there's much more benefit in doing that. So I think that is the future of training the doctors on the ward in particular, nurses as well, but the responders need to be hyper-trained. So we probably should be doing in situ simulation with short notification. The stuff we do annually is such a waste of time.
Yeah, I was going to say, we just need to put a bomb under our whole training program. It's, you know, speaking from a nursing point of view, dragging nurses kicking and screaming to an annual assessment is just fundamentally flawed. And they would be better doing 2 minutes of CPR once a week on a low fidelity mannequin with a CPR feedback device.
Agree.
Than all of this compliance-driven nonsense that we currently do.
So
you would get better CPR performance.
Agree. And our last accreditation, the accreditors acknowledged our approach, and we sailed through that part of our accreditation. We do not do annual ALS training in all of our in all the doctors.
Fantastic. One more question. You put your hand up so quickly.
It would be fantastic if we could orchestrate that. And look, to be honest, I'm an emergency nurse. I'll just declare that. So I feel like a bit of an imposter here. But you know, I think it would take a concerted effort from colleges like ASIM and KICM and ANZICS. And I think there would be a concerted effort by a whole lot of people, I think, to make that registry happen. But I don't think it's impossible. And certainly, you know, the evolution of out-of-hospital cardiac arrest registry has been quite different in each state in Australia, and, you know, Victoria's really led the way with VACAR, but now most of the states are on board with that, and now we're moving to a national registry. So I don't think it's impossible, but it's going to take time and I think commitment from a whole lot of different people.
we'll bring this to an end. Thank you very much to our speakers, and we'll see you back in here in half an hour.